Thank you. Well, good morning, good afternoon, good evening, and good night to everybody, and welcome everyone to the PROCON Kasai debate on Kasai procedure called "Did Kasai portoenterostomy reach the top of its possibilities worldwide?" I'm Yvonne Masha. I'm a pediatric hepatologist and head of pediatric hepatology and pediatric liver transplant section at the Hospital Universitario Austral. And I'm glad to introduce our remarkable experts that will develop this PROCON debate. I would like to thank Dr. Luque for inviting me to participate in the Atrevio project that makes its presentation with this first virtual symposium, in which we have outstanding speakers that will enlighten us on this topic of paramount importance for pediatric hepatology, liver surgery, liver transplantation, and research. Speakers will expose their answers to two questions in this debate. The first one is, all biliary atresia patients should be offered Kasai portoenterostomy and none proceed directly to transplantation. And the second one is the differing outcomes between centers adhere both to the surgical approach and adjuvant therapies. Each of the speakers will have 10 minutes for their expositions at each part, at the end of which we will have 10 minutes for questions. Please remember to use the Q&A box to type your questions, mentioning the speaker that your question is addressed to. You can also use the chat box for other comments. The first presenter is Dr. Mark Davenport, who will expose his points of view and experience. Dr. Davenport is a pediatric hepatobiliary surgeon. He's a professor of pediatric surgery at King's College in London and formerly president of the British Association of Pediatric Surgeons. After that, Dr. Saul Karpen will expose his insights and experience. Dr. Karpen is a pediatric hepatologist. He is professor of pediatrics and division chief of pediatric gastroenterology, hepatology, and nutrition at Emory University School of Medicine in Atlanta. Thank you both professors for being here with us today. And without further ado, I leave you with Professor Davenport. Thank you.
Thank you very much. Thank you very much for that kind introduction. Let me again see if I can display my slides. There we go. Okay, what we thought we'd do is slightly different than presented, in that what I'd like to do is just slip around the world, following one of the great science fiction authors, Jules Verne, in order to try and illustrate the variation in both the Kasai operation and also its results. And then we'll really concentrate on the two questions that have been put forward. So I'm going to go around the world in hopefully about 8 minutes. Okay, so we've got some data from North America, South America, Europe, and Asia. Let's use it. And what I'd like to first address really is this concept of incidence, if nothing else, to try and clarify what we mean by biliary atresia, because it is interesting that there is marked variation in incidence. So if we start in Japan, the incidence there is 1 in 10,000 babies, and it's a very similar story in Korea. In Taiwan, it's even more common, 1 in 6,000 babies. Taiwan has got the highest incidence of biliary atresia in the world. We don't really know what's going on in China nationally, but almost certainly it will share the same kind of incidence that we've seen in those other 3 countries. Let's move across to Europe. And these, remember, are national series. And in Finland, the disease incidence drops to 1 in 20,000. 1 in 17,000 in Switzerland, 1 in 18,000 in France, and our own series is 1 in 17,000. Clearly different from the Asian incidence. Okay, we've moved across the Atlantic and looking for some evidence of what's happening over there. There's only really the Canadian national estimate, which is about 1 in 19,000. There's some small American, USA studies. And the one I've illustrated is one from Texas 1 in 16,000, which would suggest that at least in North America, they're following the European incidence rather than the Asian incidence. Looking at data from South America, well, actually, we have no data on the incidence of biliary atresia in South America. There is a country, if I can put it like this, where East meets West. And this sort of really hits the nail on the head as far as the difference goes in incidence across the world. And that's New Zealand. New Zealand is a small country, as I'm sure you know, populated in the 19th century largely by British and Irish settlers. And its population is about 4.7 million, of which now 70% are white Caucasian. But there is the original population, the Maori, composed 16% of the population. And there's a national study looking at the estimate of biliary atresia. And in the white Caucasian population, it's 1 in 16,000. And in the Maori, it's 1 in 5,000. Clear disparity, something odd is going on in terms of the ethnic, presumably the genetic basis for this particular condition. So is biliary atresia a different disease around the world? Well, one way of looking at it is to look at the previously mentioned variants. So these are Asian series where they looked for evidence of the syndromic form of biliary atresia. So this is a multi-center Chinese study, a lot of babies, 851 babies. They could find only 3 examples of polysplenia and 2 of situs inversus. And it's the same in Taiwan and Japan. Big Japanese, this is the J-bar registry with 3,000 biliary atresia infants, and only 2.1% of them had polysplenia. These, by contrast to the Western experience and series, the top one, London, is our own experience. And as I say, our incidence of BASM is 10%. And in Canada and France, it's not that much different. So there is good evidence to suggest that there is something different that's going on when you move around the world. One of this might be associated with viruses, and in particular CMV. So let's look at this. In our English series, it was 10% overall, but we did notice a marked racial divergence. Despite them all being born in the UK, the CMV positive biliary atresias were markedly overrepresented if you are non-Caucasian. There are some Chinese studies which would also suggest that they've got a much higher proportion of cases that are virally related. So this is a study from Shanghai looking for viral DNA in liver and a specific CMV stain. And they suggested that 60% of their series of biliary atresias were CMV positive. And it's the same with that other big Asian country, 1.3 billion people live in India, and there's an awful lot of biliary atresia there as well, albeit the studies are fewer and far further between. But they are also small scale studies to suggest the same kind of proportion. So this is a series reported on only 15 cases of biliary atresia, but in half of them, they were positive by PCR for CMV. This was actually followed up by a report from a Mumbai surgeon, a pediatric surgeon, Rajiv Redkar, and he reported in his series of biliary atresia that 50% were IgM positive. So clearly something different is going on. Let's look at a few other features which may or may not explain some of the variability. Let's look at the age at Kasai. As I say, in England, currently 49 days to the time of Kasai. It's in the low 60s in other European countries, fairly consistently. And it's very similar when we get to the USA. However, if we go south of the equator, things start to deteriorate. These are not national statistics. These are single center series from Brazil and your own from Argentina. 88 days, 81 days, clearly different. And it's the same in series from India and from Thailand as well. Does that reflect perhaps the clearance of jaundice rates? Well, again, I've talked about my own results in the 60s, similar to the Nordic experience. There is variability though, 40% clearance only in France. When we get across to the USA, it is in the 40s rather than the 50s. But again, fairly across the equator, it falls to below 30, 35% or so. And that's much more akin to the experience in India Thailand, and Singapore, all with relatively poor outcomes. Let's finish in Asia, where we originated, in Japan. 63 days is the median age in Korea, with a clearance rate of about 66%, and similarly in Japan itself. Very similar for both those two countries, and indeed Taiwan. Taiwan, you'll note, is the only real country that has got a dedicated screening program based on stool color. But they achieve a median age at Kasai of about 52 days, with an accompanying clearance of 60%. We don't really know what's going on in Chinese series because there really isn't regional or national data, but it's of a degree different from the other Asian experiences there, both in terms of an older age of Kasai and a reduced clearance of jaundice as well. What's happening in South America? Well, there are papers from South America. Next one is from Brazil. The clearance of jaundice, as I've alluded to, is 33%. Your own experience from Argentina, or at least in Buenos Aires, suggests a much more outcomes akin to that European North American statistics that I've just shown. But I would like you to note the higher incidence of CMV, 36%, according to that paper. Before I go, though, I told you I would mention laparoscopy. You could say that actually Argentina and Brazil are the home, or at least the originators, of laparoscopic Kasais. The first one was probably done by Edward Esteves. And this is quite an influential paper published in the Seminars of Pediatric Surgery some while ago now. And I've just reproduced these, maybe as a starting point for a conversation, if nothing else. So these are undeniably early results, but there is a clear difference in outcomes from these two expert, minimally invasive surgeons. In the Brazilian experience, albeit using a fairly loose definition of clearance, 84% apparently, possibly much more realistically in Buenos Aires, higher age at Kasai, but a much lower clearance of jaundice rate of 32%. Okay, so what have I concluded from this short run around the globe? That there is genuinely marked variability. You need to know where you are when you're talking about biliary atresia. And there is variability in outcome, whether it's due to the disease or the methods of treatment is very much debatable. I'm now going to hand over to Saul to really try and get into the two questions that have been posed, and then I'll return to give my sort of comeback. So I'm going to stop sharing my screen now, and hopefully Saul will restart again.
Sure. No, thank you, Mark. That was really very helpful. And in the interest of, it's always great if we were together, right? Because then, it would be a lot more fun and a lot more interactive, but we'll do our best, right? So we really already see that there's an engaged audience and that they're going to, not be shy about asking questions. So please be a little bit more provocative. Both I sense that we both would really like that, because none of us have the right answers, but we also want to have the right answers ultimately. All right. So I'm gonna share my screen as well, and I'm gonna really start with something that may be a little bit more provocative and overall, what can I say? Thinking about that I want you to. Sorry, the way I'd like you to think is we're really just gonna have a pro and con, and this is all about the known unknowns. And we'll go through this, and there really have two questions that we're going to talk about over the next now probably 45 minutes. And these are, one has to land on one side of this, okay? So all BA patients should be offered a Kasai portal enterostomy and none proceed directly to transplant. That's one of the questions, okay? And Dr. Davenport is going to take the pro, I'm going to take the con, and we'll talk about this. And then the second, which was nicely outlined by Dr. Davenport about around the world, differential Kasai portal enterostomy outcomes between centers and countries are due to surgical approaches and adjuvant therapies. I'm not sure which is going to be pro and con on this, but we'll be there. So the first one, I actually want to go back in history. And this is, I know, a US-centered thing, but I think it had worldwide implications. And I want to go through this. And for many of those of us who are not new to the world, we know what this is all about. In 2002, actually, tomorrow is the 20-year anniversary I see from my dates. The picture on the upper left is the United States Secretary of Defense. And there was a question for him at a news conference. And the way he answered this question took on a life of its own, but I think it really has relevance to how we think about complex questions like the ones that we're posing, and to take them seriously, quite honestly. So could I follow up, Mr. Secretary? Is there any evidence to indicate that Iraq has attempted to or is willing to supply terrorists with weapons of mass destruction? Because there are reports that there is no evidence of a direct link between Baghdad and some of these organizations. And the way Secretary Rumsfeld answered this question, I think, is illustrative. And hopefully it translates well, and my Spanish is non-existent, so I'm going to do this all in English. So this is his answer. Off the cuff, not prepared. Reports that say that something hasn't happened are always interesting to me, because as we know, there are known knowns. These are things that we know we know. We also know that there are known unknowns. That is to say, we know that there are some things we do not know. But there are also unknown unknowns, the ones that we don't even know that we don't know. It is the latter category that tend to be the difficult ones. Now, what he's talking about is a serious issue. And he was really talking about something that the philosophers and the linguists loved, because nobody's ever talked in this language before. But I think it really has relevance for all of us as we start to think about how smart we are, or how much we know, and how much we really need to say, am I teaching something to my residents and fellows that somebody taught me that was never tested? And the answer often is yes. Some of it's good and is fine, but often some of it has no basis whatsoever. You know, I think the best example of that in our world is what used to cause ulcers. It used to be your job, it used to be your family, it used to be something else, and ends up being a bacteria that's easy to treat. So I think that we have examples of things that we really need to, you know, look and see what we want. Well, for the two questions, I really want us to think in our own brains, what about the known unknowns? What are the things we know that we really want to know about? We know that there are some things we don't know. And then the unknown unknowns, meaning we're missing the boat completely. So let me start off with a case for question one. Here's a 3-month-old. Again, it's late, but not unexpected. 3-month-old who comes in. This is the person's biopsy. This was the point where we did biopsies. You see this awful looking liver, right? Wide portal tracts, bile duct proliferation, lots of plugs. This is the trichrome on the lower left. I don't think anyone would argue that this is quite an end-stage cirrhotic at this point. And so in our opinion, again, it's opinion, there's no fact, we considered this kid to be too late for a Kasai, also malnourished. We thought that he was a poor surgical candidate. And many of us who have seen this done at other institutions or even their own, you send the sick kid to the OR, you have a sicker kid coming out of the OR. And so this was always our concern. And so this is this child's timeline, and I'm just going to go briefly through this. This was in April. By the time July rolled around, he was continually in the hospital. And we did start TPN at this point. He got worse and worse. And ultimately, he went straight for transplant. I don't know what would have happened in this child if we did a Kasai at this age. But the likely story, in my opinion, is that we probably would have shortened his time to illness, as we've seen with other kids. So we really focused on this kid to try to get him earlier. This is an old case report. We would never go this long before transplant. Nowadays, we really would probably be within 2 to 3 months and be transplanted at most. So this is just illustrative of that. And the liver, there's nothing you're going to do for this liver. You know, this is what the liver looked like at transplant. Frankly, I don't think it's any different than what it looked like at 3 months of age. So I don't know what we're doing for these kids who do present with some features, those that we can't figure out. This is one of the great unknowns, in my opinion, in the field, is who should and who shouldn't be considered for a Kasai operation. I think it's easy when we get a kid who's 30 or 45 or maybe 55 days of age. They really don't have a marked splenomegaly. And for those of us, we do biopsies, we don't see a lot of fibrosis. That's an easy decision. The harder decisions are some kids are fibrosers, and at the same young age, you may have a problem. So I think it's harder. So for both questions, I think about questions like this with a pro and a con side, and you try to associate with both. So here's the question, all BA patients should be offered a Kasai and none proceed directly to transplant. The pro for this, and what many say is, I don't have a crystal ball. I can't predict the future. How do you know this child's not going to do well? And of course, no one can answer that question. But there are no data to identify who's at worse risk. We don't know how to stratify these patients at the time of Kasai. I think we are good doctors, and we know that if they have ascites, that they're very malnourished, this is not a good surgical candidate. But not everybody presents that clearly. And I think those are the ones I would certainly strongly argue that these are unlikely to get better. And people may have ends of 1 or 2, but again, without large consortia, we may miss these patients. The cons, I think, outweigh the pros. These are poor surgical candidates for those that are more advanced. The reality check is it's a 50% success rate. It's not 90, it's 50. Transplant is a 90% success rate. And transplant is not experimental, and transplant is part of our mainstays. We have seen, but I've never seen it quantified, but there's likely an increase in mortality in infants if we continue to operate on end-stage liver disease. And in our opinion, what we like to do for those who seem more advanced, we focus on nutrition and candidacy, not hoping that the Kasai will work. Often time is the enemy on these patients. We do a Kasai, we know they're going to get sick, and we wait too long before we transplant them. And that hopefully has changed much in the last 10 years, but it still is present. So I would argue that really, as I showed on the previous slide deck, that not all BA subjects are amenable to medical or surgical therapies. And it's this time period here that we really have to start understanding it. We don't know how to stratify these patients, but I do think if they come with end-stage liver disease, if their overall childhood is going to be one where they have a 75% chance of needing a transplant or dying, and they have a 50% chance by the time they're age 2 of having something like this, I think we have to think strongly about whether or not everybody should get a Kasai when we know that proper preparation and in the right hands, which is worldwide, transplantation is the way to go. So I'm going to end there because in the interest of time, I think there's nothing more I really need to say at this point. Oh, no, there is one more thing. Sorry, I'm going to say one more thing. And I really apologize for this because I wanted to end with this point. Give me 1 second on this. Sorry about that. I was readjusting my slides before, and so now I am back. So I want to ask the following question, and it may be coming up on my 10 minutes, but I think we have enough time here. Why doesn't the Kasai portoenteroscopy cure biliary atresia? Why doesn't it? If it's a disease, it's like colorectal cyst, we take out the extrahepatic tree, everything's put together. Why doesn't it work? Well, it's an ongoing intrahepatic cholangiopathy, and we have multiple different etiologies. So I think this hope that it's going to work in everybody is not fair. I think it's not fair for the surgeons. I don't use the phrase failed Kasai. I think that's wrong. It's not, it's not on the surgeon. It's not the case. It's the nature of the disease. Some things you just can't fix because there's an ongoing intrahepatic cholangiopathy. I just don't know how to characterize those. We all know, however, that the remaining bile ducts are abnormal and reactive. In fact, work that Dr. Becerra just published, where he isolated cholangiocytes from biliary atresia livers, shows that these are not normal cholangiocytes. I agree with Dr. Davenport that absolutely inflammation and peribiliary fibrosis is playing a role in progression. The problem is that's what the liver should do in any liver disease. That's normal. And whether or not it's certainly contributory is possible, but we should expect this. I don't know if the disease can be cured in the half that can't respond to a Kasai. And maybe that half can be a quarter. That would be great. We just have this great unknown of how to identify this group. We don't know who's going to respond. We don't know who's not going to respond. But I think if we know that somebody presents with end-stage liver disease, and we're thinking about which operation to perform, we have to really think strongly about it. And so I do come back to this quick question about why doesn't it cure BA? And I think that there's just perpetuation of this ongoing process. And along these lines, there's one paper out there which I think is open for absolute discussion about its validity overall, but it's in JAMA Surgery, published about 3 years ago from a group in California, where they were comparing, they didn't call it a Kasai, they call it biliary enteric drainage versus primary transplant as initial treatment for children with biliary atresia. I'm going to give you a bottom line for this paper. They really asked the question, are outcomes better with primary transplant or Kasai? And the bottom line here is that in their database, in their analyses, and they did it in different eras, the era where there really wasn't transplant as part of their choices, meaning before 2002, and then after 2002. And they looked at the possibility and probability of survival overall, and it ends up being your overall survival was better in this analysis with primary liver transplant versus Kasai. And the mortality rates are really quite different, and the hazard ratio afterwards of whether you go one or the other leaned on the side that you're better off often in these patients to consider prepping these kids for transplant, again, one operation as opposed to two, or not. There's a recent paper that came out last week that certainly has a different take on this, and many of us also have a different take. I don't know if I have this take overall, even though I'm supposed to be fully con, but I think that it gives us some pause. And their own conclusions are the following. There is clearly, these are surgeons, a subset of patients with BA for whom good and durable outcomes can be achieved with the Kasai first approach. And conversely, a growing number of patients will have superior outcomes with the primary liver transplant approach. So in the current setting, emphasizing excellent outcomes in transplant, our goal should no longer be to avoid transplant at any cost. The characteristics of patients who would thrive with an initial Kasai procedure or with primary liver transplant still needs to be elucidated. So I'm not giving you answers, I'm giving you another take on this concept that people have really tried to look at their data and still see that they really don't know. But I think there's strong consideration in select patients that we leave their belly alone and start prepping them for transplant. So I'm going to stop my part now on question 1.
Okay.
Thank you. Thank you both. I don't know if you, Dr. Davenport, want to give your opinions in the first questions.
I haven't actually presented my argument yet.
Okay, and after that, if you agree, I was wondering if you want to make this a real debate and making questions each other, you two. As we know, after the symposium we have at the end, they meet the expert for questions of the audience. So I think we all agree that it will be very interesting if you two have a real debate.
Okay, happy to do that. Let me see if I can
Thank
get
you.
my slides up again. They disappear from my desktop as soon as I stop looking at them. Okay, can you see my slides now?
Yes, perfect.
Yep, okay. So these are the two questions that have been posted. Not really questions, if you see what I mean. There's not actually a question mark at the end of any of the sentences, but nonetheless, I get the point. Should biliary atresia patients be directly referred for transplant and not undergo Kasai portoenterostomy? A terrible proposal, it has to be said. So what I'm going to present a little bit is some evidence. Evidence, we all love evidence, and this is actual, real clinical evidence in a series. And what I thought I would do would present the extremes of biliary atresia. So I'm going to talk a little bit about some of those exceptional babies that come early and that you get to a Kasai operation before 30 days of age. And then by contrast, I'm going to show you some experience of the converse, those that are late presenters. And I'm going to choose the arbitrary dividing line of 100 days. So they come to your attention at more than 100 days. So let's first start with this exceptional group of less than 30 days. So this is the King series, and we have 40 of these babies, 7% of our series, and they all had a Kasai operation at less than 30 days. Why was that? Why did they come to attention so quickly? Well, when you look and break them down, they have a very different sort of phenotypic spectrum. 35%, only 35% were isolated. 30% of them were cystic biliary atresias, and there were 13 with the biliary atresia and other abnormalities, typically BASM. Again, unexpectedly high by comparison to the others. Importantly, none of them were CMV. None of these were CMV positive. So why do they come to attention? Well, as you can imagine, for the cystic biliary atresia, you can pick it up on the maternal ultrasound. So 22% of this cohort actually presented antenatally. The diagnosis may not have been apparent because that they often were misdiagnosed actually as choledochal cysts, but nonetheless, they were picked up. They entered postnatally a diagnostic stream leading to the correct diagnosis, and they were operated on early. So as I say, all of them got a Kasai operation, and 80% cleared their jaundice. And I think this illustrates the limits of the Kasai operation, 80%. I don't think we're going to get any better than that realistically in our lifetimes. What happened to them? Well, as you might imagine, given that clearance of jaundice is the #1 prognostic indicator, our 5-year native liver survival for these was 62%. Our 10-year survival, 58%. So they've gained, if you like, 10% on those that have a Kasai at more than 30 days. Okay, so if that's the best that we're going to expect, if that's a limit, what about the other extremity? Let's look at those who come to our attention or have an operation greater than 100 days. It's an arbitrary figure, I must admit. So I've taken these infants actually from the national series, which obviously half of them are from Kings, but 48 of these infants representing 5.5% of the series as a whole. What happened to them? Well, let's look at the breakdown again. Completely different. 81% were isolated. By contrast with the previous series, only 6% were cystic biliary atresias and 12% had biliary atresia and other anomalies. Now, this is a national series, so I haven't actually got complete data on CMV because the other two centers don't do it routinely or don't report it routinely. But if I extrapolate from the King's experience, 15% of this will be CMV positive, higher than those that are less than 100 days. But we had a choice. We had a choice and we made a selection, and the majority, 56%, did indeed undergo a Kasai operation at a median age of 122 days. What happened to them? And I think this is my most important argument for it. It's very difficult to predict, even on the basis of this extreme part of the age spectrum. 52% cleared their jaundice to normal, 52%. Okay, we're going to come back to these in a minute. The other option is primary liver transplant, and 37% of this cohort did undergo a primary liver transplant. But, and this is a problem, we haven't got pigs' livers as they have pigs' hearts in Maryland on offer. They have to wait for their transplant. So the median age at transplant in this UK series is 8.9 months. One poor child had to wait till their second birthday to get a transplant. And that clearly comes at a cost. And there can be deaths on the waiting list. And I think there were 3 infants who were deaths on a waiting list, waiting on the transplant list. There were other 2 deaths in this particular cohort. They were post-transplant, post-secondary transplant, if you like. So this just illustrates that this is a critical group. This is where your highest mortality is. And if I can illustrate that by these Kaplan-Meier survival curves now, the top line, the red line, is the overall survival in the whole group. And it is lower than expected, lower than the figures that I've previously told you about. So the 5 and 10 year survival, 85%. That's 5% what we would anticipate and expect from the entire biliary atresia population in the UK. The blue line is the native liver survival for those that underwent Kasai. So it is very like the Kasai that's on under 100 days. The 5-year native liver survival in this group was 52%, dropping at 10 years to 47%. No difference. So I appreciate that they've undoubtedly got cirrhosis and they do start off at a worse place, but nonetheless, if they clear their jaundice, they can be longer term survivors. So the key reason is, well, how do you choose? How do you choose between a Kasai Porter and enterostomy? Because I think it is genuinely a valid option. If they are reasonable, if they are come at a reasonable age. So the primary liver transplants came at an unreasonable age. So the median time of presentation for them was 156 days. So I certainly wouldn't do consider a Kasai with an infant that presented at, say, 6 months of age. We try and use clinical features to try and discriminate. The ultrasound, is there marked nodularity of the liver? Is there marked ascites? These are the ones that probably should be fast-tracked to liver transplant. But Kasai Porter enterostomy may be your only alternative. There are certain scenarios whereby transplant is not indicated, and there are clearly parts of the world where it is not an option. Primary liver transplant where there is undeniable evidence of advanced cirrhosis. So some of them, I will do a mini laparotomy and see what's inside, not only for confirmation of the diagnosis, but sometimes they've got very marked portal hypertension, choledochal varices even, and to try and attempt a portal dissection in that kind of scenario would be somewhat foolhardy. But of course, you've got to involve the parents in any kind of choice like this. So we do, and they may well have different views. Okay. Let me go on to the second question if I can, and then I'm going to hand you back to Saul. And that's really trying to explain some kind of differential outcomes between the centres and the countries. And I'm going to sort of give you 2 bits of evidence, if you like, from that perspective as well. One includes the surgeon centre experience, and I believe the solution to that is some kind of centralisation policy, or at least regionalisation, because there are marked differences, for instance, in the UK experience compared to France. Very similar sized countries, the same economic performance, excellent health service, but the outcomes are clearly different. Open versus laparoscopic. Obviously, there are people that would favour laparoscopic surgery. There's very little that's actually published showing benefit, but one very vocal proponent of laparoscopic Kasais is a guy called Yamataka from Tokyo. Good friend of mine. We've written joint papers together on the subject. What he doesn't tell you, and he does have some decent results, there's no question of that, relatively small numbers. What he doesn't tell you is he keeps his infants in for 6 weeks after the operation. 6 weeks. This is a minimally invasive procedure. Why does he do that? He does it to look at their stool on a daily basis. And if the stool colour veers towards being paler than it was on the day before, he ramps up their steroids again. These babies get a ton of steroids. What he also does is reoperate on them. Up to 20% of his series, he will reoperate, admittedly another laparoscopic procedure, but nonetheless, he strives desperately to offer them a surgical operation. So again, laparoscopic procedures in some people's hands, but maybe not for the rest of us. In terms of adjuvant therapy, again, you've heard Saul talk about the disparities in adjuvant therapy. I'm not going to talk about steroids anymore or antibiotics, but I am going to just talk a little bit about antiviral therapy. So firstly, surgical disparity. This is our program of centralization. And this is just, again, to give you a context of what's happening in Europe at this point in time as to how we manage biliary atresia as a whole. We started our program in 1999, and the government dictated in England and Wales that you could only be referred if you suspected biliary atresia into 3 centres, 3 English centres. And that's how we sort of progressed. And as the years have gone by, the countries, there are separate countries, Scotland, Northern Ireland, have abandoned doing their Kasai operation and they refer into the 3 English centres. And for the past 10 years, the Irish have also done the same. So next week, I'm going to do 2 CASIs from Ireland. So we've completely centralised our practice in the UK and Ireland, but our message has been taken up by other members of the European community. So Switzerland have centralised their practice. Finland have centralised practice to Helsinki. The Netherlands, Denmark, Norway, Sweden, all have centralised their practice, done in single centres in those countries. This year, Germany have politically decided to centralise the care and management of biliary atresia. I don't know into how many centres, I think 3. And similarly, Poland, they've got 1 centre in Warsaw. So there is a definite shift towards centralisation, at least in Europe. Okay, I said I was going to talk about our results a little bit more detailed with CMV. So let's do that now. Just to refresh people's appreciation of what CMV actually is, because we're thinking of it in terms of biliary atresia, but actually congenital CMV, which is not CMV-associated biliary atresia, is vastly more prevalent. It's the most frequently identified viral cause of mental retardation in the newborn, the leading non-genetic cause of hearing loss. And as I say, 1% apparently is the newborn population is affected by congenital CMV. Big population, causing a lot of problems. We know in a certain select few, it is capable of infecting bile duct epithelia. And there's several studies which have shown that. Let me just show you, before I talk about the treatment options, what our experience with this particular condition was. We published this in 2015, and it was a retrospective single center review, and we defined our population as exhibiting IgM positive antibodies, IgM positive. And as I say, it accounted for 10% of our population. I've already emphasized the racial disparity, but they were also older at the time of presentation compared to the CMV negative. And this just illustrates that their livers were different as well, a much more inflammatory liver in association with CMV positivity. And the thing that's really stood out, however, was that they did dreadfully badly after a CASI. Only 8% of the CMV group cleared their jaundice, 8%. That's terrible. And it also had a knock-on effect on mortality. They had a worse expectation of survival as well. Now, we thought about, could we change this? Could we change our outcomes, if nothing else? And we looked for ways of treating it, and almost certainly you'll be more familiar with treatments for CMV than I am, but there are effective treatments for congenital CMV. This is just one illustration of a randomized placebo-controlled trial where the endpoints are hearing loss. And this, in this ganciclovir group, completely abolished hearing loss in infants diagnosed with congenital CMV. So it's potentially extraordinarily ineffective for these particular kinds of infants. Could we therefore apply it to our babies with CMV associated with biliary atresia? Well, this paper was published, to say, a couple of years ago, and is the one Saul referred to. What we did also factor in was their viral load, which was very variable. They were all IgM positive, but there was a variable viral load, not easy to say. And we also equated that with a number of different indices. So one thing that did become obvious was there was an inverse correlation with the age surgery. The older children, the older presenting children, had lower viral loads. And also there was a relationship with a number of different liver enzymes. So I've illustrated here the AST values. And as you can see here, there is again an inverse correlation. The higher the AST, the smaller the viral load. And this also was found with APRI, surrogate marker of fibrosis as well. Again, highly statistically significant. What does it mean, or what can we imply with that? Well, the liver damage, the actual liver damage itself, appears to be associated with the later phase, when the body, the immunological system, is already clearing the virus naturally. These have not had any kind of treatment. And this is indirect evidence, of course, of the autoimmune cholangiopathy, where it's the virus itself which has triggered some kind of abnormal, damaging autoimmune cholangiopathy. Okay, so let me update the figures. Saul did allude to this. This is hot off the press. This is actually published today. So I put 2021. Its publication date is today, 2022. And by this stage, we've got 50 infants with CMV positivity. And in this particular study, I compared them with 100 controls. These were ERA-controlled controls. So these are CMV negative infants who bracketed, if you like, the CMV positive ones. And again, it demonstrated this relationship with ethnicity and increased age at Kasai. But what I wanted to really show you is our antiviral therapy. I appreciate there's only 12 of them, and I have no defense for that, but nonetheless, it's 12 more than many other centers. What happened to those 12? Well, 10 out of the 12 cleared their jaundice to normal, 83%. The ones that didn't have specific antiviral therapy, 22% were clearing their jaundice. Better than our original one, but nonetheless, still very much lower than expectation. And this had a knock-on effect on the need for transplant as well. So the antiviral therapy group had a reduced need for transplantation. This is the actuarial survival curves for this particular study. The controls is the heavy black line, again, as one anticipates. Our CMV positive, but without antiviral therapy, is the red line. Very different from controls, and also different from the blue line, which is our CMV group who did undergo antiviral therapy. As I say, we started off with ganciclovir in the early part, and now they get oral valganciclovir. Okay, so I'm going to sort of finish off there and again hand over. Hopefully I've talked about surgeons, and one of the things I do want to emphasize is that age at surgery does make a difference, but age in certain circumstances is also got a positive correlation with the age at the surgeon as well, because experience does count in large amounts. So the experience is a key factor in a surgeon operating on a child with biliary atresia. It's a rare disease, there's no question. Other people may tell me how effective their laparoscopic experience is. I hope I've shown some of the benefits of centralization. And again, we're going to talk and argue about adjuvant therapy as well. So perhaps I will hand over, but not before this advertisement. I hope you can all see this. 2 years ago, we proposed that we had a face-to-face meeting of all the interested parties in biliary atresia in Bruges. This was sadly snookered by the COVID epidemic. We had a webinar last year, and this year we're actually going to do a face-to-face meeting in Bruges in June this year. So again, all of you will be interested in biliary atresia. Clearly, you are all welcome. And a further abstract call will be going out soon. So I'm going to sign off now and stop sharing my slides.
Thank you, Mark. Thank you, Saul. I'm wondering how to proceed. Do we have some questions? So do you want just to open the Q&A box and hear some questions from the audience, or do you want to?
Dr. Luke, can I maybe start this, because we have a small bit of time, and we have a small bit of time for debate, right? So I'd like to just really bring it back to the first question, and in our remaining time, maybe we could just talk about that, because I think that's the most troubling opening, and I really appreciate how Mark approaches it. But I wanted to think that one of the questions was asking me from Dr. Melgarejo about saying that KPA is not a definitive treatment or a bridge. That question, I think, is a good question, but that's not my point. My point is that we really want to look at each of these patients, and it's an easy out to say they're individualized. But I do want to make the point, and I think that Mark says it as well, there are kids who shouldn't get a Kasai. And so my direct question is, are there kids who shouldn't get a Kasai?
Okay, I entirely agree with you, Saul. No particular problem at all about that. As I say, it's the difficulty is, how do you know? So there may well be small sick infants that are in end-stage liver disease They won't tolerate a haircut, never mind a Kasai.
Correct.
So, you know, that's an easy decision to make. Whether they actually get to a transplant is maybe a different matter.
Well, there's
so
2 points. Yeah, go ahead. Sorry.
I was going to say we've had 2 examples of early deaths in children that were clearly profoundly sick at presentation. They weren't transplantable. They never got transplant. So it is very much that's an easy decision to make in them. I do think that the age is not just the only thing to make a distinction on, which is why I did. Well, that's the reason for that particular example, is purely on the basis of that cutoff. What happened to them? Because some people do say, well, if it's 95 days, should you be offering? This is a spectrum disease, and we encompass an awful lot of variation within the body of the infants that we're calling biliary atresia, and they don't all respond the same. So whether their liver biologically is 100 days, who knows? Who knows?
I think that's fair. I mean, I think we agree on this, but I think what we can't do, at least this is maybe the point of a pro and con debate, is say everybody goes this way and everybody goes that way. But I believe in giving the freedom, honestly, to the families, as you pointed out in your slide, as well as the individual caregivers. Like, for example, where we are in North America, I have to say that the waiting list issue is not a point of our discussion anymore. Not for at least 5 to 10 years, but that's not universal. You know, that's not around the world. So we don't use that. I mean, most of our kids are transplanted by 6, 7 months of age, to be quite honest. You know, once we identify them as, you know, the total bilirubin doesn't drop, they're clearly progressing, they're in the hospital, we all know that they're going to die if they don't get a transplant. So there's no magic that's going to happen. The point of the adjuvant therapies, and I like this idea that bigger kids in the OR for the transplant surgeon are often sometimes better. The pushback I get from the transplant surgeons often is that they would like to have a belly that was never touched. And so it doesn't mean it's
never make the life of a transplant surgeon easy. That's my motto.
Right. Well, that's what they say at times. Correct. But I think that it's a good point, is that there's often with those kids who have complications, peritonitis, varicose bleeding, it really is worse, you know, because of the operation, meaning the Kasai. But I'm with you. I'm pro Kasai. Please don't walk across this that somebody gives me a label on my email or my Twitter feed that I'm anti-Kasai. I'm 100% pro Kasai. What I'm anti is the fact that it's absolutely necessary in everybody, and we have a rational discussion as to what to do next. We use biopsy as part of our armamentarium. I don't know if that's where that is, right? You know, because a percutaneous needle biopsy is good, but it's not perfect, right? And so we often see a difference even in the 4 days between percutaneous biopsy and a wedge biopsy or a needle biopsy at the time of Kasai. We see a difference, but the difference is always worse. You know, it's always a worse histology. So we do use needle biopsies as part of this decision-making. Do you?
Not necessarily as decision-making per se. We use it more as a diagnostic. So obviously those that go to primary transplant, we really need to say this is because they've got biliary atresia. How are you going to prove it? So it's more part of the diagnostic stream rather than anything else. But again, it's a factor. It's a factor.
Dr. Mallow, are there any questions from the audience?
Actually, I have a question for you, both of you. I think maybe Dr. Carpin will have made hard time just to answer this. I don't want to be provocative, but you told us to be just provocative in this. Are we in a statistical dilemma, as artificial the statistical dilemma, when we are always seeking in a native liver survival as a surrogate of survival, patient survival? Because we have the liver transplant as a safety net. So how can we just compare in this? Because we are saying that it kind of that we saw early signs that you will need a transplant in the future. So let's get the transplant done because you will need it in the future. I think, does it make sense? instead of waiting until you have a clinical signs of that you need a transplant, and you keep going with your own liver, and you say it's not Kasai versus liver transplant, it's Kasai plus liver transplant, and in a timely fashion. Because when we say that liver transplant is a lot better, but we are missing 2-3% of waiting list mortality and 4% long run mortality, 5% more. So it's not that just liver transplant is 100% survival and Kasai a lot less.
I think it's I can maybe start, because this is really a hepatologist question, but I really want to hear what Mark says, because we take care of these patients, as you know, and we're so excited. They're in school. The rest of them are normal, right? You know, these are joyous outpatient annual events. You know, we see these kids, they look great, but their spleens are sometimes 20 centimeters and their platelet count is 65. But that alone is not an indication for transplant. And so if this child is being a child, that's our goal. You know, flipping the switch to transplant evaluation, again, in North America and many parts of the world, I can only speak from my experience and North American, is really quite simple. You know, we do wait for complications because we don't know if there's going to be a better therapy. I'm not a big fan on shunts in any of these kids as they get older. I'm really not, you know, might as well transplant them because we know the history and the future. But what I do think, and I wanted to end with this, at least my part, and be quiet, is what we're missing are real worldwide registries. There are many kids who don't make it to a registry, and we have an excuse for it. They were very sick, they never make it, you know. So there really is more complications, and especially for those with small numbers. The children registry, the one that's in North America, nothing's perfect, but you know, it's at least multi-center, and it's now almost 20 years old, and we have 3,000 biliary atresia patients. So at least from the North American phenotype, we can probably start to get some of these questions answered. I think what we're not going to yet answer, and Georgie and I have talked about this before, I really would like to get some type of biomarker on those who would likely not respond to a Kasai. So we do know earlier, may not be at the right age, but that's it. We are working at better identification earlier. You know, we and others have worked on direct bilirubin measurements. That's hopefully going to be part of the thinking of pediatricians and get us these kids earlier. But that's not the whole story. We've all seen kids at 110 days of age who don't have splenomegaly. And these are non-fibrosers. That's it. They're just kids who are not big. But we've also seen kids at 45 and 60 days of age who already have a rock hard liver. You know, so I love it, you know, when I hear Dr. Davenport say, look, we want to do an honest assessment and maybe say we're going to bail and not go forward with the Kasai. But that requires experienced surgeons. I've been lucky to work with experienced surgeons who do that and say, I'm not going to touch this liver. This is one that we really need to stop and go forward. So I don't know if that's an answer to your question, Carlos, but I don't think that using transplant as a prevention for future problems is a good idea until the child really has evidence that they have bad liver disease.
Okay, I think Dr. Maza, I think we are.
Yes, I think we are.
We have to move on. Yeah.
Yes, and well, I want to thank everybody for attending this virtual activity, and thanks a lot, Dr. Davenport and Dr. Carpen, for your fantastic debate. Remember that we have at the end of the symposium the Meet the Expert, so the questions could be answered there. And I want to encourage once again everyone to participate, to join the Attribute project that will improve our knowledge for sure in biliary atresia. Thank you all, and we move to the next lecture. Thank you.